Okay, thank you very much, Kata. So I'm going to be talking about the cost-effectiveness analyses that we have been doing in the ASSIST project, but also more broadly what's out there for other improvement interventions. I'm going to be talking about cost-effectiveness analysis for a very simple intervention to begin with, and then look at how that is different to cost-effectiveness analysis that's done for improvement interventions. Then we'll look at a very quick we'll take a very quick look at a literature review that was done, that we did a little while ago, and also conclude with what we know about cost-effectiveness analysis. So I thank the IOM very much for inviting me to this, and I thank them very much for the beautiful breakfast and the lunch. Unfortunately, I got word from the caterer that all of the food there was contaminated with an undisclosed infectious agent, and you're all doomed to be very violently ill tomorrow. And the good news, that's the bad news. The good news is that I anticipated this problem, and I asked a pharmaceutical company to prepare an antidote for this undisclosed infectious agent, and it's actually in those Ferrero Rochers that are being circulated around. So we could actually, and there are only 48, there are about 60 of us here, so there might be a fight for the last ones. So we could do a very simple cost-effectiveness analysis on this kind of intervention. And the reason I'm telling you this is because, or going through it, is because this is, when we talk about cost-effectiveness in health economics, this is what we really mean in general terms for most of the analyses that are done. So in this case, we know that you're all going to get sick, and we know that the Ferrero Rochers are 100% effective in eliminating the chance that you will be violently ill tomorrow. And so it's very easy to determine for yourself if the treatment, in this case the Ferrero Rocher, is cost effective. And in this case, because I've given you the probabilities, it would just be a matter of looking at the cost of the medication, and I should note that I'll be charging $100 each for these. But you will be able to determine if it's cost effective for you. Now, if you are in the circumstance where you have a regular job that pays you for being sick, if you take the day off work, then there is no cost for being ill. And then you just have to decide, is it worth me spending $100 to not feel sick tomorrow? For those of you who are self-employed or who are working on an hourly basis, you would have to decide, is it worth paying the $100 to have this treatment if I could then work over that period tomorrow? And if you earn more than $100 a day, then you would actually be saving money by taking the Ferrero Rocher and giving me the $100. So that's just a very simple cost effectiveness that's done generally in health economics. In improvement work, it's quite a bit different. In some ways, the basic principles are the same, but it gets very complicated very quickly, because let's say if there was the USAID mission in Liberia asked one of the implementing partners to do some work on improving the quality of care in Liberia, in places that are affected by the Ebola epidemic, then that work, that improvement work, would affect, of course, the response to Ebola. So there would be some changes in the epidemiology of Ebola in response to that, but there would also be changes in a lot of other things as well. So one would assume that the treatment for malaria that was available in those clinics, which were part of the improvement implementation, that would change as well. Maybe it would get better, maybe it would get worse. The same with maternal health services, the same with childhood infectious diseases services. All of these things would change. The same as HIV services. We would have to, if we're doing a cost effectiveness analysis of this intervention, we would have to collect data on all of those things. So the costs of those things, and we would usually use process measures to look at this, and we would have to then use, if we wanted to change those process measures to patient outcomes, we would have to do modeling for those. And so it involves a lot of data, a lot of epidemiological modeling. It gets very complicated very quickly to work out these things. So this is why it's difficult to do cost effectiveness analysis on improvement activities. So there are many issues. As I said, there are many effects, both good and bad, that we have to consider in this situation, or in any of these situations where we're doing improvement in complex social environments. We usually look at process measures as opposed to outcome measures, which is a weakness of a lot of the studies, but we can use epidemiological model, but then that opens us up for criticism because as the epidemiological assumptions that we're making and including in the models, are they correct or not? We also have to make assumptions as to how long the quality improvement or the effects of the quality improvement intervention are going to last. So we might be there for 6 months, 9 months, 2 years or whatever. What happens when we leave? Do we assume that things just go back to how they were at baseline, or are those improvements going to continue year after year, or is there going to be some slow attenuation or whatever? We have to build those kind of assumptions or that sort of information into the cost effectiveness analysis if it's going to be credible and if it's going to be accepted by the broader health economics and medical literature community. Also, there's the issue of looking at our programs. You know, we are outsiders. We're coming in from, in our case, USAID, or on behalf of USAID, and we're doing the implementation. But what if we left, and what happens when we leave if the local Ministry of Health provides personnel who do the improvements in the places or spreads it across the country? We have to make assumptions about how effective that would be, and we have to make assumptions about how many personnel would be used for those kind of situations. So it gets very complicated. And also we have to consider whose perspective we're taking for the analysis. So quite often in the project that I work on, the ASSIST project, we take the perspective, at least primarily, of USAID. But does that really help the country in which, for whom we're doing this, this analysis? Not really, because once USAID leaves, they are the ones who are going to have to implement the program. And so we need to consider the costs to society for them so that they can decide, using all of the information that we have, whether this intervention to improve care is cost effective for them when they're doing the implementation. But that is not to say that we shouldn't do these. They're difficult for sure, but you know, medical research in general, health research, health systems research, it's difficult. So what? Just get over it and do them. That is my overall overriding philosophy, and I'm going to talk a little bit more about that in just a moment. So we did a colleague and myself did a very brief and very quick literature review to have a look at what was out there in terms of cost effectiveness analysis in the PubMed literature. There were many, many studies, thousands of them, that mentioned cost and effectiveness of quality interventions, but very few of them did actual cost effectiveness analysis and had results from those. And actually we found only 10. And this is where it gets to be a little bit of an awkward example of narcissism and self-flagellation, because of those 10 studies, there were 6 countries there that were involved in these studies, and the ASSIST project did 5 of them. So we looked at a lot of different interventions. None of them were really the branded kind of interventions, even the ones that I authored, where we said, okay, this is collaborative improvement, or this is SBMR, or whatever. There was not that kind of branding. There was descriptions of what those cost effectiveness analyses interventions were. But, you know, in terms of using the branded, the 6 branded ones that we're looking at here, there wasn't that in these studies. Of those studies, of the 10, there were 7 that were rated cost effective and 3 that were rated as cost saving. So in other words, those 3, they not only improved health outcomes, but they also saved money overall. But there were several limitations to the studies, and this is not a list of limitations for all of the studies. Some of them had more than one of those, but most of them had weaknesses of some sort, and it goes from no control groups, and in fact the no control groups issue was actually a case with all of those studies, unfortunately, including the 5 that I did. I'm somewhat embarrassed to say. Short time frames, no generalization or difficult generalization, and poor quality by CEA standards. So in other words, the BMJ and some other journals have outlined specific criteria for cost effectiveness analysis in regular, you know, when cost effectiveness analyses are done for medications and for devices, et cetera. And there are certain rules that you should follow in terms of how you do the modeling and the confidence intervals that you report and the sensitivity analyses, et cetera. Well, these studies did not rate very highly on those criteria that are reported for other journals. So in summary, regular evaluation for quality improvement is hard, for sure. And for cost effectiveness analysis, it's even harder because there is this added element of trying to collect costs in difficult circumstances. That, for sure, is no excuse not to do them. We should definitely do them and try to do them as rigorously as we possibly can, always. There are very few out there, and they all had positive results, which does beg the question, how much publication or confirmation bias was there? And I don't have a good answer to that. And it does beg the question that Alex was noting before, is should the folks doing the implementation of these improvements, should they be evaluating it? That's a good question. There was no head-to-head comparisons of the 6 types of interventions that we've been discussing in this. In the grey literature, there is some, not necessarily of those 6 interventions, but for example, we have looked at different ways of doing collaborative improvements in various settings. And overall, just as a general comment, this is a weak spot in the improvement field. In the international arena, it really isn't spoken about very much, and the way that improvers in general talk about cost effectiveness analysis is not the same way that health economists talk about cost effectiveness analysis. And I think that's a great problem, and I think it in some ways undermines the improvement field. And it is something that we are working on in the ASSIST project to try to improve the rigor of the studies, but there are limitations. And one of the things that I was going to say is that, just following up on what Alex said a little while ago about, doing that big randomized trial for improvement interventions, and I'm totally up for that, and I think many others in this room are, but could we borrow some money? Could you get your CDC folks to give us some of the money for that kind of study? And we would definitely do it, or we would support having it done on our interventions, but we're totally up for it, but it's just a matter of resources. Okay. All right. So that was all I had to say. Thank you.
Thank you very much, Edward, for that overview of the state of play of the field, as well as the critical self-appraisal of some of the literature that you've in fact produced. Over to you now, Dinesh.